Today we are going to cover breathing exercises. Breathing exercises. There are several forms of breathing exercises that can improve ventilation and gas exchange. Breathing retraining. A number of breathing retraining techniques are used to relieve and control dyspnea in patients with COPD and asthma. Physiotherapists often teach diaphragmatic breathing and pursed lip breathing to improve ventilation, ventilatory efficiency, and gas exchange. In addition, patients may benefit from Buteyko and Pepworth breathing techniques and yoga training. These are the other breathing techniques which are also helpful in patient treatment. Although none of these breathing techniques provide consistent improvements in all patients, specific techniques may provide benefits for individual patients. Okay, for a specific patient, specific exercises are uh, covered. Diaphragmatic breathing exercises. Diaphragmatic breathing exercises are traditionally performed to improve ventilation, decrease the work of breathing, mitigate dyspnea, means to reduce the relief from dyspnea, normalize breathing pattern, and reduce the incidence of post-operative pulmonary complications. Yet there is some other controversy as to whether teaching diaphragmatic breathing in breathing exercises actually achieves any of these goals. One review of the literature regarding the efficacy of diaphragmatic breathing reports that there are both beneficial and detrimental effects of diaphragmatic breathing in patients with COPD. So in COPD, patients with COPD have both positive and negative effects of diaphragmatic breathing. Potential benefits effect include, what are the positive effects? First is the tidal volume improvement, abdominal motion movement, pulmonary function, and respiratory rate and arterial blood gases. These all will improve. Potential deleterious effect means bad effect of the diaphragmatic breathing consists of paradoxical chest wall motion. Paradoxical chest wall motion means when we inspire the air, the chest will move inside, not outside. It is possible that persons with moderate to severe COPD or marked hyperinflation of the lungs without diaphragmatic motion or change in tidal volume during diaphragmatic breathing may be poor candidates for instructions in diaphragmatic breathing. Conversely, a person with COPD who have faster respiratory rates, low tidal volumes that increase during diaphragmatic breathing, and abnormal arterial blood gases with adequate diaphragmatic movement may benefit from diaphragmatic breathing. Conversely, person with COPD who have faster respiratory rates, low tidal volume that increase during diaphragmatic breathing, and abnormal arterial blood gases with adequate diaphragmatic movement may benefit from diaphragmatic breathing, because it is clearly mentioned that diaphragmatic breathing improves tidal volume and abdominal motion, pulmonary function, respiratory rate, and arterial blood gases. So therefore it will help in COPD patient also. The development of abdominal paradoxical breathing pattern and worsening dyspnea and fatigue during or after diaphragmatic breathing indicates that diaphragmatic breathing should be modified. Example, use of more upright body positions and trunk flexion or discontinued. The development of abdominal paradoxical breathing pattern and worsening dyspnea and fatigue during or after diaphragmatic breathing indicates that diaphragmatic breathing should be modified. Example, use of more upright body positions and trunk flexion. Trunk flexion with upright body position or discontinued if any complication will take place. The techniques for teaching diaphragmatic breathing exercises are as follows. Have the patient assume a comfortable position that optimizes diaphragmatic breathing. Example, sitting supported semi-Fowler position. Semi-Fowler position is like this. No, not like this. This semi-Fowler position at a 30 to 45 degree angle from the ground. Marked hyperinflation in patient with COPD with marked hyperinflation of the lungs and paradoxical breathing patterns, sitting with trunk flexion is recommended. In addition, it has been suggested that a posterior pelvic tilt may facilitate diaphragmatic breathing, and that internal rotation and abduction of upper extremities may inhibit upper chest movement. So these are the two positions which should be avoided to enhance the breathing pattern. Explain the purpose and goals of exercise and demonstrate the desired result. Provide tactile stimulation by placing one hand on the patient's abdomen over the umbilicus and the other on the upper chest while asking the patient to breathe slowly and comfortably. Follow the patient's breathing with the hands and note the movement of abdomen versus the upper chest. Normally, the lower hand will rise with inspiration as the diaphragm pushes the abdominal contents down, and fall with expiration as the diaphragm returns to its relaxed position. Motion of the upper chest should be minimal. Visual stimulation can be added by having the patient observe increased motion of the hand over the abdomen and decreased motion of the hand over the upper chest. While auditory stimulation can be provided by therapists through the provision of loud inspiratory and expiratory sounds corresponding to the patient respiratory cycle. Monitor several respiratory cycles as the patient completes an exhalation. Instruct the patient to breathe more deeply with verbal cues such as fill my hand with the air or take a deep breath into my hand. Notice the expansion under the lower hand. Instruct the patient to exhale normally. If the patient has difficulty with diaphragmatic breathing, instruct him or her to sniff, means to inhale through nose, first to promote a diaphragmatic contraction and then breathe as described previously, or apply a firm quick stretch using the hands on the abdomen. A stretch is applied just before inspiration. The counter pressure caused by the quick stretch will facilitate the muscular response. Using the verbal commands as noted previously readies the patient for action. Some practitioners recommend the use of abdominal muscle contraction and the and expiration in order to lengthen the diaphragm and increase the force generating capacity, termed abdominal diaphragmatic breathing. And some practitioners recommend the use of abdominal muscles contraction at and expiration in order to lengthen the diaphragm and increase its force generating capacity. Manual stretching exercise. Then have the patient place his or her own hands on the abdomen and upper chest and repeat the same procedure while following the verbal cues for the therapist. Continue practicing until the patient can demonstrate competency in diaphragmatic breathing. Example, doubling of abdominal tidal exertion with reduced upper chest exertion and increased tidal volume during diaphragmatic breathing. In breathing retraining, diaphragmatic breathing exercise can be progressed to higher levels of difficulty by having the patient perform the exercise while sitting unsupported, standing and then walking with cues initially and then sequentially removing the various cues. Breathing control. Breathing control is a variation of diaphragmatic breathing that acknowledges the altered lung mechanics that occurs with obstructive lung disease when the diaphragm is often flattened and at a mechanical disadvantage, favoring the use of accessory muscles. It involves normal tidal volume breathing using the lower chest and, if needed, the accessory muscle with the goal of decreasing the work of breathing and improving airflow. Pursed lips breathing. Another technique that can be effective in improving gas exchange is pursed lips breathing, PLB. which aims to show the rate of expiration increases the volume of expired air and limit dynamic hyperinflation during periods of increased ventilatory demand, including daily activities and exercise. Pursed lip breathing has been shown to decrease the respiratory rate and minute ventilation, improve gas exchange, both oxygen and carbon dioxide, increase tidal volume and reduce the work of breathing, thus relieving dyspnea and increased exercise tolerance. However, not all patients with airflow limitation experience benefits with the technique. Some studies have failed to demonstrate a reduction in dyspnea, and others have shown increased breathlessness at rest and during exercise. So this is a patient which is sitting flexed position for relieving from dyspnea. Physical therapist instructs a patient in use of pursed lip breathing and forward leaning posture in sitting to relieve dyspnea. Pursed lip breathing is often used spontaneously by patients with COPD to relieve dyspnea, or the technique may be require instruction by the physical therapist as illustrated in figure 7.5. The patient should assume a comfortable position as the therapist describes and demonstrate the techniques for pursed lip breathing and explains its effects, benefits. With the hand on patient mid-abdominal muscles, the therapist instructs the patient to inhale slowly through the nose. The patient is then told to let the air escape gently through the pursed lips, avoiding excessive use of the abdominal muscles, giving the patient a verbal cue such as imagine you want to make the flame flicker on a candle that is being held at arm's length from you, will enhance the patient understanding and performance. The patient is directed to stop exhaling when abdominal contraction is detected. The patient is directed to stop exhaling when abdominal contraction is detected. When able to perform pursed lip breathing without cues, the patient substitutes his or her own hands or the therapist's. In breathing retraining, pursed lip breathing can be progressed in difficulty by eliminating the tactile feedback of the hand on the abdomen, advancing to standing, and finally proceeding to other activities such as ambulating or riding a stationary bicycle while continue to use the technique. Other breathing retraining techniques are patients with asthma often complain of respiratory symptoms, dyspnea and chest tightness, as well as anxiety, lightheadedness and fatigue as a result of dysfunction breathing despite pharmacological treatment. It has been documented that 30% of survey responders pursue breathing techniques to relieve persistent symptoms. Several breathing techniques have shown promise in improving various outcome measures, subjective symptoms, medication requirement, peak flow, airway reactivity, and exercise time. But reliable conclusions were limited by small sample size and by methodological problems. The Buteyko technique is a series of breathing exercises that focuses on slow nasal breathing, breath holding, controlled pause, and relaxation. Reduction in medication use and symptoms have been reported. The PEPPER method is a multi-component program of breathing and relaxation exercises that are designed to reduce rapid shallow breathing during times of stress. It emphasizes relaxed deep breathing, diaphragmatic nose breathing, and has been shown to ameliorate respiratory symptoms and improve quality of life. In general practice population of patients with mild to moderate asthma, yoga breathing training includes a number of rhythmic breathing techniques accompanied by simple hand and body movements. Pranayam uses prolonged expiration, abdominal diaphragmatic breathing, resistant inspiration and expiration, and yogasanas and chanting maneuvers. Other yoga breathing techniques that slow breathing without voluntary breathing hold include Nadi Shuddhi, Sheetkari, and Bhramri. Improvement in peak flow, medication requirements, and frequency of exacerbations have been observed. Segmental breathing exercises now. Segmental breathing exercises, also called localized expansion breathing exercise or thoracic expansion exercises (TEE), are used to preferentially augment localized lung expansion. The goals are to increase the redistribute ventilation, improve gas exchange, aid in re-expansion of air space, mobilize the thoracic cage, and increase the strength, endurance, and efficiency of the respiratory muscles. Although evidence supporting the effects of segmental breathing exercise on regional ventilation is lacking, these exercises appear to be beneficial for the other goals mentioned. Segmental breathing exercise use manual pressure as proprioceptive input to encourage expansion of specific areas of the chest. Hand placements, unilateral or bilateral, commonly used by therapists as listed in table 7.10. Table 7.10. Where is table 7? Hand location for the therapist and focal area of lung being emphasized. Hand location: subclavicular areas, upper lobes, anterior mid chest, right middle lobe and lingula, anterior lower ribs, anterior basal segments of the lower lobes, lower lateral costal areas, lateral basal segment of the lower lobes, posterior lower chest, posterior basal segment of the lower lobes, posterior mid chest with scapula abducted, superior segment of the lower lobes. After identifying the area of treatment, the therapist's hands are placed on the appropriate part of patient's chest, applying firm pressure at the end of expiration. The therapist then instructs the patient to take a slow, deep breath in through the nose to fill my hand with air while applying gradual diminishing resistance to permit full range of motion. Maximal inspiration is sustained for 2 to 3 seconds and then the patient exhales, which is sometimes assisted by the patient's manual pressure. Once the patient demonstrates understanding of the previous steps, she can be instructed to perform the exercise with his own hands or a towel or belt. The patient places a towel or belt over the area of treatment, grasps the end with his or her hands and applies firm pressure at the end of the expiration. As the patient is taking a slow deep breath in through the nose, she is applying a gradual diminishing resistance through the towel or belt, adjusting to allow full range of motion. Maximal inspiration is sustained for 2 to 3 seconds and then the patient exhales, which may be assisted manually or with the towel belt. In addition, proprioceptive neuromuscular facilitation (PNF) techniques using patterns involving the upper extremities and trunk coordinates with inspiration and expiration can be performed by the PT for patients with the neurological deficits. With the therapist's hand placed so that the fingers are aligned with the contracting muscle fibers, a quick stretch is applied just before inspiration in order to increase the force of muscle contraction. Then at the end of deep inspiration, repeated stretches are applied as the patient is asked to breathe in more in order to increase chest expansion. Now, glossopharyngeal breathing. Patients with high level quadriplegia are often instructed with glossopharyngeal breathing, in which the patient swallows air into the lungs in order to increase vital capacity. Vital capacity, which is a lung air volume capacity. Glossopharyngeal breathing is used to augment cough effectiveness, provide internal mobilization of the chest wall, and improve quality of life by allowing periods of ventilator or phrenic nerve stimulator independence and more effective phonation. The patient creates a pocket of negative pressure within the mouth by dropping the tongue to maximize the internal space, thereby causing air to be sucked in. The patient then closes off his lips and forces the air back and down his throat with a stroking maneuver of the tongue, pharynx and larynx. Now, incentive inspirometry. Incentive inspirometry involves the use of visual or auditory feedback device to visual or auditory feedback device to encourage reproducible slow deep inspirations. Incentive inspiratory is commonly performed by post-operative patients in order to reduce the incidence of pulmonary complication associated with surgery-related shallow breathing, bed rest, diaphragmatic dysfunction, pain, and impaired mucociliary clearance. Two types of incentive spirometers are commonly used. A flow incentive inspirometer typically consists of one or more chambers containing the table tennis-like ball that are elevated by sufficient inspiratory airflow. So this is the inspirometer. Patient using incentive inspirometer. A ball is placed over here inside the spirometer, which will resist the flow of air. A volume incentive spirometer consists of bellows or pistons that register the volume inspired and can be indicate whether a preset volume goal is achieved. Instruction in proper technique is critical to the effectiveness of incentive spirometer, especially with flow device. A rapid inspirometry rate will elevate the balls to the top of the chambers with a relatively low volume breath, or a deep breath at a slow flow rate may achieve a high volume without moving the balls. With the patient in a sitting, semi-polar or supine position with the head of the bed raised 10 to 15 degrees to relieve diaphragmatic resistance applied by the abdominal contents, the patient is instructed to take 3 or 4 slow easy breaths with normal exhalations in between. After these breaths, the patient exhales slowly but completely, place the mouthpiece in the mouth, forming a tight seal with the lips, and then performs a slow deep diaphragmatic breath, minimizing any upper chest movement in order to elicit the visual cues of the apparatus, plunger, balls rising, lights flashing, etc. The inspiration is sustained as long as possible to allow collateral ventilation of the well aerated alveoli with those that are poorly ventilated. Before the mouthpiece is removed and the patient relaxed to allow expiration, this procedure is typically performed 10 times every hour while awaking.